Welcome to Grand Rounds. It's my pleasure to introduce Rajnish Mehrotra, who is one of our own nephrologists here, who will be speaking to us today. He began his medical education in India at the Institute of Medical Sciences in New Delhi. His internship and residency he completed at the Medical College of Pennsylvania, as well as a chief residency year. He then did fellowship in nephrology at the University of Missouri, and following fellowship, joined the faculty at UCLA, and ultimately rose in the faculty as professor in 2010. The University of Washington was able to steal him away in 2012, and he is currently a professor of medicine in the Division of Nephrology, section head of nephrology, and section chief at Harborview Medical Center. He has numerous honors and awards, really too numerous to mention, including many international honors. A prestigious award for the International Society of Peritoneal Dialysis was received in 2006. His publications are on a variety of nephrology topics, focusing on modalities of dialysis. He has over 180 peer-reviewed journals, 25 book chapters, and is the PI on greater than 20 research grants. His current research grants really focus on the effectiveness of different renal replacement therapy modalities, including between peritoneal dialysis, hemodialysis, and transplant. And today he'll be talking to us on the current state of dialysis therapies in the United States. Join me in welcoming Dr. Mehrotra.
Thank you. What I thought I'll do is, rather than delve into detail into one part of dialysis, just give an overview from my vantage point and how I see the therapies today and the possible directions we hope to moving forward. So in somebody who has ESRD, as long as there is not a medical contraindication for it, the treatment of choice is renal transplantation. Of course, it's challenging for everybody to get a kidney transplant, in part because there is a waiting time. And from the time that I was a fellow up until now, the waiting list for a kidney transplant has grown tenfold. And about 100,000 people that are waiting on a kidney transplant waiting list in the United States. We do only about 15,000 a year. So every person who has ESRD, even if they're a candidate for transplant, has to spend at least a part of their life, if not all of it, wait on dialysis. And then we can do dialysis in a dialysis facility or at home. Both hemodialysis and PD can be done in center or at home. But the dominant forms of therapy that account for over 98% of all patients are in-center hemodialysis or peritoneal dialysis. There are about 10,000 patients in the country right now that are doing home hemodialysis, which has made a comeback from the time when it started in Seattle in the early 1960s. It's really made a comeback right now. So the four things that I thought I'll talk about is just for you to get a sense of what the population of patients undergoing dialysis in the country looks like. It is growing and changing. The issue, which in my mind, from a health services point of view for nephrology, is the biggest issue that is out there, is a safe transition from CKD to ESRD. Then briefly give an overview of what we've tried to do to reduce the cardiovascular risk in people on dialysis. And then a focus on improving patient-reported outcomes and how complex the treatment is, how complex the care transitions are. For us to ensure that patients are able to move through those transitions safely and effectively, we need to make sure that we provide them the support that they need. And so patient-reported outcomes is an important area of interest for people on dialysis. This is where we have come from starting 1980, from the time we started keeping tab on the numbers of people undergoing dialysis. As you can see, in 1980, there were less than 50,000 people on dialysis in the country. And as of 2012, for which we have the latest counts, there's about 450,000 patients in dialysis. There's another 150,000 patients that are living with a functioning kidney transplant for a total ESRD population of about 600,000. So in this period, the U.S. population increased 37%, but the dialysis population increased ninefold. So there's been a substantial, much faster increase in the number of people in dialysis than the growth in population. And there are many reasons for that, and I'll just briefly go over that in a minute. What has also happened is that more and more people per million population had been starting dialysis, and that kept on until 2006, where it peaked at almost 390 people per million population that was starting dialysis. Since then, the incidence of ESRD actually has been declining. It's been declining year after year, so that the most recent number we have is 353.2 per million population, and this is in part because of success in reducing incidence of ESRD in people with diabetes. So diabetic ESRD is coming down, which is the primary driver for the reduction in the incidence of ESRD in the United States. What has also happened is through this period of time, the risk for death for people starting dialysis is also continuing to go down, which is in part a success, but I want to just begin by saying that the annual mortality of people on dialysis is about 20%. So there's 1 in 5 patient that starts dialysis will no longer be alive in a year. We made strides in that, but there's still a long distance to go, that the mortality still is about 18% or so a year for people that are starting dialysis for the first year that they are on dialysis. What about the different types of dialysis? As you can see, this is just looking at this from the period of 2001 through 2008. This is the increase in number of people on dialysis. And as you can see, that virtually all of this growth that happened, I've just taken this as a snapshot, from 2001 through 2008, was because of increase in number of people that were going to a dialysis center to do dialysis. So essentially, if you look at it as differently, from 2001 to 2008, about 100,000 more people net were being treated with dialysis. Of all of that increase, about 1.4% was because of increase in PD, 2.4% because of increase in home hemo. This home hemo increase was larger than that for PD, but in absolute numbers actually is very small, because only about, say, 500 people start on home hemo every year. And so small changes in numbers when they're small can result in large, relatively seemingly larger proportional changes in use of home hemo. Home hemo still is a very niche therapy used by very few people. And this has happened despite what we have learned from around the world, that the risk for death for people starting hemodialysis or PD is the same. There are 2 ways of looking at this, that the 2 therapies are equally successful or they're equally poor in maintaining people's lives, because the average life expectancy of a person starting dialysis in the United States is still about 3 years. So, and if you look at people that are 10 years out, only about 12% of people are alive. So all of us know of people that have lived with ESRD for a long time, but 9 out of 10 people that start dialysis would not be alive 10 years out. So survivorship is uncommon. But getting back to the point in terms of distribution of modality, the use of what has increased up until 2008 was largely in-center hemodialysis. That was not driven because of medical reasons for differences in outcomes by therapy. And this is despite the fact that to the society, costs for PD are consistently lower. We spend, as a society in this country, about $50 billion a year on providing dialysis support. About $32 or $33 billion is Medicare dollars, and the rest is from private insurers. And so when there is such a large discussion that is happening about costs of medical care, if 2 therapies provide equivalent medical outcomes, it is important then to see what the limitations are in increasing the use of a therapy that is cheaper. Because if you're talking about fixed budgets, you can treat more people for the same money if the therapy is cheaper, as long as you're not compromising someone's health. That is the last thing that you'd like to do. Medicare has historically incentivized the use of peritoneal dialysis, and in starting 2011, they implemented changes that to the healthcare system, to the providers of dialysis services, PD was more lucrative, if you were, for want of a better word, than in-center hemodialysis. And system-wide changes have happened through the country that there's occurring now. As you can see, the numbers were flat up through 2008, and there's been this rapid upswing, so that I predict from starting 2008 through the end of, say, 2016, the number of people on PD in the country would have doubled from about 28,000 or so. If I could just go back, 28,000 in 2005, for example. The last numbers we have are from 2012, when it exceeds 40,000 people. My suspicion is that this number is closer to 50,000 now. So there is this continued increase in PD has continued. What is interesting observation, and this is work that we recently completed, is that overall PD is not used as much, but it is particularly not used as much by racial and ethnic minorities. And you can describe it in any different ways. You can look at, right here is the blacks, the Hispanics, the Asians, and other. These two panels, this reflects PD, this reflects home hemodialysis. And as you can see, every racial ethnic group, when you adjust for differences in the health and well-being of these individuals, have a much lower probability of being treated at home than the white population. And the disparity is even larger for Hispanics, for example, with home hemodialysis. We don't really know the reasons for this difference, and I think we're just scratching the tip of the iceberg in terms of what the reasons are. At least one of the things that we explored was, did it have anything to do with the health insurance an individual had at the time they started dialysis? Since we broke this down into Medicare, Medicaid, other, or people that were initially uninsured, at least the health insurance didn't seem to have a bearing on the lower use of home dialysis by racial ethnic minorities, whether it was for PD or for home hemo. But I think this is important to understand, and I'll close up, when I close my talk, I'll close up why I think it's particularly important for us to be doing so. So for my first of the four things that I was going to cover, what I've tried to say is that the growth in the number of patients undergoing dialysis has substantially outpaced the growth in the U.S. population. And that is because people are living longer, so they are at longer risk for getting kidney disease. There is the increased societal burden of diabetes mellitus. But I think as importantly, access to maintenance dialysis is not truly universal. There were people that would not have been candidates for dialysis in the past that are now considered for dialysis, and is, I think, to a large part, is the reason why the patient population has grown. The incidence of treated ESRD has finally begun to decrease, mostly because of decline in rates of diabetic ESRD, and I hope that this trend is maintained. Notwithstanding that, the number of dialysis patients, the absolute numbers, is likely to continue to increase, albeit at a slower rate, because the mortality has gone down, and the transplant wait times have become longer. And so more and more people will be on dialysis, even though the incidence of ESRD is going down. And I think in that context, it's imperative to bend the cost curve that we've heard in other contexts for care for this increasing population. And I think that is in part, that's not the primary reason, but at least in part my advocacy for more people to be dialyzed at home than are presently dialyzed, because it's a cheaper therapy. Moving on then to transition from CKD to ESRD. This is an area in the care of patients in nephrology that is in greatest need for care innovation. Not as much as scientific breakthroughs, as much as innovations in delivery of healthcare. And this is part of the work that I do with the American Society of Nephrology, with the Dialysis Advisory Group, in which we came up in what we think are step-by-step approach in preparing people for a life with dialysis. I'm just going to focus, in the interest of time, on this issue of timing of start of dialysis. What has happened not just necessarily starting 1996, but from the time that we've been keeping track, is that people are being started on dialysis at a level of GFR that is higher than it used to be. And this may have plateaued to an extent, but not quite as much as you think it has. And virtually every observational study that has looked at this has shown that higher the GFR at the time of start of dialysis, higher is the risk for death. Clearly, that's an association. That is not cause and effect. But there are two potential explanations for this. This could be that people that are sicker are the ones that are poorly tolerant of the uremic state, and they end up needing dialysis at a higher level of GFR. And what we are seeing is a risk because they're just sicker. Or it could be that their harm is being done by the dialysis therapy itself that is putting them at a higher risk for that. And the only way to get around that is to do a clinical trial, which was done in Australia and New Zealand, called the IDEAL study, which had 32 centers in Australia and New Zealand, and they enrolled individuals with GFR between 10 and 15, and they randomized them to either starting dialysis early at a GFR of 10 to 14, or wait up until it is between 5 and 7. And I'm just going to not go through this, just to get to the point, is that the intended difference, if I could just go back, the intended difference was to be between, let's say, 12 and 6, a difference in GFR of 6. So they were wanting to wait up until the GFR fell to between 5 and 7 in the late group to start dialysis. What ended up happening is that 76% of patients that were randomized to start late couldn't wait to be started on dialysis. They got sick before the GFR got that low, and they ended up being started on dialysis. And so that the difference in GFR was not as much as they had planned for it to be, but that was necessary for them to keep the patient safe. Nevertheless, the median time of randomization to start of dialysis was a little less than 6 months. And what the bottom line was that there was absolutely no difference in any of the outcomes in people that started dialysis either at a higher GFR or a lower GFR. There was no difference in cardiovascular events. There were no differences in infectious events or complications of dialysis or total healthcare costs. Predictably, dialysis costs were higher in people that started early, but if you looked at the total healthcare costs, they were not different because they were just distributed differently. So my take on data is that it's not necessary then to start dialysis at a predetermined level of GFR. But the analogy I often give my patients is that it's best for us to prevent them from falling off a cliff and then dangle them a rope. So it's best to expect when somebody's getting sick and start dialysis timely. But then, so to put it differently, if there's a patient that is otherwise asymptomatic, dialysis can be safely postponed, and it is also cost-effective. That time should be used for dialysis preparation, to educate people about dialysis therapies, securing a permanent access. Starting with a central venous catheter is not desirable. But in patients with advanced CKD, but that have a higher GFR, but they have uremic symptoms, or they have difficulties in managing volume, or electrolyte abnormalities, dialysis should not be denied. Dialysis does prolong life of most, if not all, patients with ESRD. And initiation of dialysis does result in improvement in sense of well-being. Every year I have patients that would say, "Doctor, I didn't know how badly I felt up until I started dialysis." And so the experience of IDEAL studies suggests that most patients are likely to get symptomatics at GFR between 7 and 9. Challenges remain. Uremic symptoms are nonspecific. They appear so slowly that patients adapt to the lower level of functioning. And so waiting for patients to endorse uremic symptoms prior to offering dialysis is not tenable. And I think where we are in this, it's the domain of art and not the science of medicine. We've not come to the science part of it. It is clinical judgment that dictates when you start somebody on dialysis. 46% of patients start dialysis with either no care by a nephrologist or care by a nephrologist for less than 6 months. There are many reasons for that. 80% of patients that start hemodialysis do so with a central venous catheter, which is not the preferred access type, and puts patients at risk. And so I think a lot of work that the nephrology community needs to do in partnership with the general medical community is to improve the safety of transition from CKD to ESRD. Let's talk about cardiovascular risk. I started off by saying that the annual mortality of patients that start dialysis is about 20%. Was 20%, we've made improvement, but still 18%. It's still very high. So the median life expectancy for people starting dialysis around the world is between 3 to 5 years. That is on an average. And the higher risk for death is in part because of complications of coexisting illnesses. A lot of these people have come in very sick when they start dialysis because of diabetes, because of hypertension, because of other problems that they have. So it's complications of coexisting illnesses. There are complications of the uremic state, and then their treatment at times puts them at risk. And then there are some potential risks that are directly related to the dialysis therapy itself, because it's an aggressive therapy that has its own risks that we have to be mindful of. If you look at this, that irrespective of dialysis modality, the single most common group of causes of death is cardiovascular. Now, so in the general population, it's estimated that about 30-35% of all deaths are cardiovascular. But in people on dialysis, almost 50% of all deaths are cardiovascular. If you break this down, it becomes even more different than the general population, because the single largest group is sudden cardiac death. So these are people. So these are people that are just have a cardiac arrest and die, and we don't know what happened to them. And there's no necessarily identifiable trigger that is causing sudden death. So if I was just to give you my take is that sudden cardiac death is substantially more important in how we keep records. The contribution to total death, I think, is somewhat overestimated. In studies that have been done in general population, for patients that have a sudden cardiac death, and if you do a cardiac cath on them, a substantial majority of them have a coronary thrombus. And so it is thought to be ischemic in origin that triggers the arrhythmia that leads to death. There are not many studies of angiography or autopsy in people with ESRD that have sudden death. But the ones that have been done have shown that the incidence of coronary thrombus is much, much lower. It's only about 20-30%. So 70-80% do not have an occlusive thrombus that results in their death. Also, as you well know, that there are criteria for primary prevention of sudden cardiac death that have been brought out by the ACC-AHA that says that if a patient meets certain medical criteria, they should get AICD even before they've had an episode of arrhythmia or sudden cardiac death. If you were to use that same criteria for people with ESRD, you would still miss 70% of all sudden deaths. And there are people that believe that the most tenable approach is that every person with ESRD should have an AICD. It's a very expensive proposition that needs to be tested in clinical trials, and clinical trials are underway. At least pilot trials are underway of placing AICDs in every person that starts dialysis with a control group to see what the outcomes are before larger trials are done. So what is putting these people at higher risk? Some of these are non-modifiable. Age and male gender are not modifiable. We are used to thinking of traditional risk factors for cardiovascular disease: hypertension, dyslipidemia, hyperglycemia, smoking, obesity. Then there are risk factors that are uremia specific, and I've listed them only partially. And I'm sure if you were to talk to a group of nephrology researchers, they will say that their favorite one is missing from this list. But there are a lot of them: LVH, volume overload, inflammation, anemia, mineral metabolism. I can go on and on. And then there are risks of each individual dialysis therapy. Pardon me, what I've listed here is all that relates with PD. This is not to say it's only PD that puts people at risk. For example, we've learned myocardial stunning that happens during hemodialysis procedure, even in the absence of hypotension, that results in progressive loss of LV function over time and is associated with a higher risk for death. So we have recalibrated, for example, from those studies in how aggressively we remove fluid with the dialysis procedure. So be as it may, the point I'm trying to make is that there are many potential reasons why people with ESRD have such a high risk for cardiovascular mortality. The question is, are there interventions that we can modify that we know will reduce cardiovascular risk? And this is the list of failures. So this is not for want of trying. With all the observational studies showing that a low hemoglobin is associated with a higher risk for death, when EPO came about, we thought if we normalized hemoglobin, if we corrected anemia, we would actually have patients live longer. Not only did we not have them live longer, we had them die sooner. We had a higher incidence of stroke and a higher incidence of cardiovascular risk when we tried to normalize hemoglobin so that we have calibrated back in what the target hemoglobin is in people with ESRD. There have been many clinical trials that have been done, many of them funded by the NIH, in looking for interventions that could reduce the risk for death. These are some of the negative studies. For example, in terms of dose of dialysis, how much clearance we achieve, what kind of dialyzer we use, so that what range of toxins do we remove, use of phosphate binders that don't contain calcium. Homocysteine lowering has failed in people with kidney disease as much as it has failed in the general population. And then I'll briefly talk about statins and where we are with regards to statins. There are some studies that have not been done, and in my opinion are not even worth looking at for this population. For example, aggressive glycemic control. This is not to say that aggressive glycemic control is not important for the health of an individual. I don't think it's going to translate into a reduction in cardiovascular mortality in the lifespan that we know a dialysis patient has. So I really don't think that intervention is important. So what is important then? So we know that in the general population, statins are very effective in reducing cardiovascular mortality. This is the first trial that looked at this in people on dialysis. This is called the 4D study, and this is patients undergoing hemodialysis that had type 2 diabetes were randomized to placebo versus atorvastatin. So this was done in Germany. They had almost 1,300 patients with type 2 diabetes that were randomized, and the primary outcome was a composite of cardiac death, not non-fatal MI or stroke. What ended up happening in the study was actually in people that got atorvastatin had a higher incidence of stroke and a lower incidence of cardiac death and non-fatal MI. So that the composite outcome was a null outcome in that there was no reduction in risk for death in people with diabetes undergoing hemodialysis that got atorvastatin. There's other studies that have been done since then. I just want to bring you to the largest study that has been done to date, which is called the SHARP study. The SHARP study was a study done out of UK in which they had over 9,000 patients with advanced CKD or those undergoing dialysis that were randomized to receive a placebo or simvastatin plus ezetimibe. Zetia is the trade name for that. And the primary outcome was first major atherosclerotic event, non-fatal MI, coronary death, non-hemorrhagic stroke, arterial revascularization. Mind you, what's not on the list is sudden death, which is the single most common reason for people to die, and that was a deliberate adjustment in protocol when the study had started, with the recognition that sudden death in people with ESRD is not likely to be ischemic in origin, unlikely then to be affected with therapies that reduce the atherosclerotic burden. What they found was a 17% reduction in major cardiovascular events, but there was absolutely no effect on all-cause mortality or cardiovascular mortality. So essentially, the effect of statins in people with ESRD is much smaller than in the general population, to the extent that there are expert groups that have come around to concluding that it is not necessary for us to check cholesterol or prescribe statins in people with ESRD. Intellectually, I'm not there yet. I still think that there's potentially a subgroup of people that could benefit from that, and I'd like to give them the benefit of doubt. But that is where the state of the art is in terms of studies that have been done. There are some positive studies. It's not all failure along the way. There is the study on beta blockers in which this is a small study of a little over 100 patients that had heart failure. And this is class 2 or class 3 symptomatic heart failure that was randomized to carvedilol or placebo and followed for 2 years. And at least in this group with low EF, treatment with carvedilol was associated with a lower risk for death than in people that got a placebo. And so one of the things, I just want to mention this parenthetically, one of the challenges that we are learning more about is that drug selection is very important in people with ESRD, particularly for antihypertensive drugs, because some of these drugs are dialysable. And so, for example, carvedilol is not a dialysable drug, but atenolol or metoprolol are very readily dialyzed. And so you're not getting sustained steady-state levels if you use a drug that is readily dialyzed every time a person undergoes dialysis. So one potential reason for what we are seeing with carvedilol is because it's not a drug that is dialyzed and we achieve steady states of the drug. The same thing applies for the dual renin-angiotensin-aldosterone blockade. In the general population, we walked away from it, in part because of the higher risk for adverse events related to the kidney. The difference in people with ESRD is that ACE inhibitors are readily dialyzed. And so in somebody who you then choose to have dual blockade, they may finally be getting blockade of the renin-angiotensin-aldosterone system. And I think there's a need for us to move away from using ACE inhibitors in the ESRD population because those drugs are dialyzed. Be as it may, getting back to the same study, the same group that studied carvedilol had these patients at class 2 or class 3 symptomatic heart failure patients. These patients were getting 4 times a week hemodialysis, that were getting ACE inhibitors. They were randomized to get telmisartan or placebo. So they were either getting telmisartan with an ACE or ACE with a placebo, and followed them for 3 years, had a significant reduction in all-cause mortality, cardiovascular deaths, and hospital admissions for CHF. So at least this one study seems to indicate that dual RAAS blockade is potentially of benefit in people with ESRD, in those that have impaired LV function. There's this study that I want to bring out also is that the study with spironolactone, for example, was in the general population in patients with heart failure, was published, 10, 15 years ago. We've always been a little concerned about using spironolactone in people with ESRD because of risk for hyperkalemia. This is a study that was done in patients on PD, in which they are actually more likely to get hypokalemia and not hyperkalemia. This was done in Japan, in which they had 158 patients that were NYHA class 1 or 2, that had been on ACE or ARB for 3 months, that were randomized to spironolactone 12.5 to 25 milligrams per day, followed for up to 2 years. And the outcome here was LV mass done by MRI. And so what they demonstrated in that those people that got spironolactone had actually regression of left ventricular hypertrophy when they got spironolactone compared to those that were not. So there's a follow-up trial in the hemodialysis population from Japan that has actually shown a lower risk for death in people who got spironolactone undergoing hemodialysis. So I just want to then present what we are doing at the KRI, the Kidney Research Institute. We are a part of an NIH-funded consortium in which we are testing, we call it the HDNT Consortium, Hemodialysis Novel Therapies Consortium, and we're doing pilot studies for 3 interventions, and one of those 3 interventions that is promising will then take it forward to do an adequately powered clinical trial for heart outcomes. So we're looking at spironolactone in part because of the encouraging studies that have come out. This study is already underway. We're enrolling patients for this. I think study-wide, some 50 people have been randomized. What we're on the threshold of starting is anti-inflammatory therapy using anakinra, and then changing gut microbiome using p-inulin. So I think work still needs to be done in improving cardiovascular risk, and this is where we stand. I think patients undergoing dialysis are at a higher risk for cardiovascular events and mortality. Sudden cardiac death is the most common underlying cause for death. The vascular disease in patients with ESRD differs in important ways from that in the general population. And interventions that have consistently been shown to reduce risk for death in the general population are much less effective in patients undergoing maintenance dialysis. What we need to do is to identify risk factors that are potentially unique to the ESRD population, but the attempts thus far for non-traditional risk factors has mostly been ineffective in reducing this higher risk. The ones that are successes are beta blockers and dual RAAS blockade. That may be of benefit in individuals with impaired LV function, but these results need to be validated in other studies. So the work is continuing for us to identify interventions that can reduce the high cardiovascular mortality in this population. I want to then move to another important part, which is patient-reported outcomes. Most patients that have ESRD have one or more coexisting medical illnesses. So these are classic patients that have multimorbidity. They have diabetes, they have cardiovascular comorbidities, they have hypertension. A dialysis patient in the United States is hospitalized on an average 1.9 times per year. So 2 admissions per patient per year. They spend about 12 days every year in the hospital. This is on an average. They have a 30-day rehospitalization of over 30%. The number nationwide is about 38%. 38% of people on dialysis, when they get admitted to the hospital, are readmitted within 30 days for reasons that may or may not be related to the primary reason why they got admitted. And it is not surprising with all else that is going on with them that when you actually query them about their health-related quality of life, they don't rate it very highly. In addition to the high burden of disease, one cannot forget the high burden of treatment. I don't know of a chronic disease in which we ask patients to do so much on such a regular basis for so long, in which we have people that come in for dialysis, for hemodialysis, for example, 3 times a week, 3 to 4 hour treatments. That requires 4 to 5 hours of commitment for every patient, for every treatment. We tell them that they cannot have sodium, they cannot have potassium, they cannot have phosphorus, but they have to eat a high-protein diet. They cannot drink fluids. We ask them to take bucket loads of medications. The median pill count for people on dialysis is 19 pills a day. And many of them have complex regimens that you need to take this with meals, but this is the one that you need to take between meals. So we have to be very mindful of what we are asking our patients to do. It is easy for us to say, oh, that patient doesn't listen to what we say. But see what we're asking them to do. I think that's quite a bit. And it is in this context, I think modality choice for me becomes very important for an individual patient, is in what we are asking a patient to do, let them have a voice in how they want their lives to be, and let them choose the therapy that they think is going to be best for us and not what we tell them to do. This is a study that we did some years ago from 3 different parts of the country in which we just had people count the number of pills that they take through the day. And as I said, the median pill count is 19. 25th percentile is 14. The 75th percentile is 26. And here's this patient with 79 pills a day. So I think it is quite a bit that we ask our patients to do. It is not surprising that a higher pill burden is associated with lower physical component on the health-related quality of life. And so we have to do a lot with our therapy to improve the patient experience of their lives with dialysis. It is complicated by comorbid depression. Many studies have been done. This is a pooled analysis of almost 200 cohorts with 46,000 patients from around the world. And this is looking at different ways for measuring depression. And this is a SCID, which is the Structured Clinical Interview, is the gold standard for the diagnosis of depression, not the depression scales we use. Using that, almost 1 in 4 patient that is undergoing dialysis has depression. And so it is not surprising that the prevalence is as high as it is. There have been at least 10 studies that have looked at the severity of depressive symptoms using a whole range of scales and have shown that patients undergoing dialysis that have depression, the more severe the depression, higher is the risk for death. There is perhaps 1 negative study out of 15 or so that have looked at this. So it's a consistent predictor for mortality. So the question is, why would depression be associated with mortality? And I find this study intriguing. This is a meta-analysis now published 15 years ago. Is not surprisingly that people that have depression are significantly more likely not to adhere to their prescribed regimen. And the consequences of not being able to adhere to their treatment regimen in a disease as complex as ESRD are substantially greater than in those without. So there is at least a potential explanation why people with depression undergoing dialysis are at a higher risk for that. We've learned a lot in how common depression is and what toll it takes on people with ESRD. However, for most patients, depression is neither identified nor treated. So this is a study, this is the Dialysis Outcomes and Practice Pattern Study, and they looked at the proportion of patients that were diagnosed by a physician to have depression versus self-report of at least 2 depressive symptoms on the scale. And as you can see, the concordance was extraordinarily low. So most patients that were depressed were not identified by their physicians to be depressed. And this is actually a much more interesting clinical trial. It was a health services clinical trial in which they elicited 3 symptoms. They elicited depression, pain, and sexual dysfunction in people on dialysis. And they used one of 2 ways to get that information to the physicians. So these patients were randomized to one of those 2 groups. The first was that they administered the scales and gave the results to the physician and say, now take care of this. The second group was nurses were trained to receive the results. They were given evidence-based recommendations, and the nurses they didn't give them the results of the scales, but they said, this person probably could benefit from sertraline. It didn't matter how that information got to the physician. 85% of the time, depression was not treated. They were either nor was it treated, nor were patients referred for further evaluation, even if the nephrologist felt uncomfortable in doing that. So there's a lot of work that needs to be done in this. And the reason for reluctance for treatment of depression is because there is so little data on what works in people with depression that are undergoing dialysis. This is a study that is done in New York and Brooklyn in 2 dialysis units in which patients were randomized to individual CBT, cognitive behavioral therapy. It is a form of psychotherapy. This, rather than the patient going to a therapist, the therapist came to the patient in the dialysis unit while the patient was undergoing dialysis. And then they followed, the treatment was, the patients were randomized either to immediate treatment or they were waitlisted and treatment was started 3 months later. So every patient got treated, but they had a period in which there was a treated and an untreated group. And as you can see, people that were treated had a significant improvement in their depressive symptoms. The BDI scores improved. This is Hamilton Depression Scale. This is the quality of life measure. This is the amount of weight they gained between dialysis treatments. So they had significant improvement in depressive symptoms. Of course, this was a single-center study done in 2 dialysis units, and this needs to be validated. There are even less data on the treatment of depression with drugs in people with ESRD. As you can see, there's only 1 clinical trial that enrolled 14 patients, fluoxetine versus placebo. The depressive symptoms were improved, but the difference was not statistically significant. And there's a whole host of non-randomized studies that have been done. So in part, how important depression is, how little we know about the efficacy of treatment. We have a study that is ongoing that we're leading from here out of Seattle, but it's a national study. It's a multi-center clinical trial in which we're doing this in Seattle, in Dallas, and in Albuquerque, and we're testing 2 hypotheses. The first is in dialysis patients that have depression or dysthymia, an engagement interview significantly increases the acceptability of treatment. This is in part because there still remains a stigma about a diagnosis of depression in patients that are reluctant then to accept treatment for the same. The trial is underway, and at least early on, we can say that about 50% of patients that are potentially eligible for study say no, which is consistent with, we're doing better than what is out there for acceptance of treatment for depression, but still it's a high proportion. And the second hypothesis is for us to compare the efficacy of individual CBT to that of antidepressant drugs. So we are enrolling the study. The study is expected to be completed in 2017, and we'll have, hopefully, the first adequately powered data to compare the efficacy of 2 common interventions for the treatment of depression, not only in depressive symptoms, but also on measures of adherence and other patient-reported outcomes. So I'm just wrapping up. I just have a couple more slides to go through. Hopefully we'll have time for questions then. So what I've said in this part of my talk is that ESRD is associated with a high burden of disease, but let's not forget the burden of treatment. The treatment burden is very high. I think it's very important for us to better manage the patient's symptoms and to identify modifiable interventions that improve patient-reported outcomes. I've not even talked about sleep and pain, which are and itching, which just are truly problematic for people with ESRD. And at least we're trying to make progress in focusing on depression with the hope that identification and treatment of depression may allow patients to better navigate the complexities of having ESRD and improve their sense of well-being. So in how we do dialysis is how we do it. The FDA recognized, this is in 2011, that there is a need for innovation in the technology of dialysis, and the devices section of the FDA came up with a competition. They said that you submit ideas to us, we'll identify 3 interventions that we're not going to give you any money, but we promise to work with you to take it to clinical trials and to practice very quickly. You can bypass our regular procedures in doing so. And they selected 3 of them. One of them is the wearable artificial kidney, which I think some of you may have heard about. Victor Gura in Los Angeles is the one who has invented this. But we were the first ones here in Seattle to have completed the clinical trials with artificial kidney. We've had, I believe, I was not involved in it, but 8 or 9 patients completed 24 hours of treatment with a wearable artificial kidney. And the data analysis is complete and is under peer review right now. Then researchers at UCSF are working on what they call as an IRAD. So this is a wearable kidney. This is an implantable kidney. This is to be functioning like a pacemaker so that you actually implant it and it's doing dialysis. And they're in early phases of testing. So this is the second innovation that went through the FDA that is being expedited, if you were. And the third is the hemo-access valve system. It is a startup, I think in the Southeast, I want to say Atlanta, that is working on it. It's a new generation arteriovenous graft that has valves at the end. And what the goal here is that when there is no dialysis going on, there is no blood that is flowing through the graft. And that can take away potentially a lot of problems with the graft should that not be the case. And so those are the ones that they've partnered with the FDA for accelerated innovation. It's still going to be probably a decade or more before any of these come to fruition, but at least if they come to fruition. So what did I say? So the number of patients undergoing maintenance dialysis is likely to continue to grow, albeit at a slower pace. And I think, at least in the United States, the use of home dialysis, particularly PD, is likely to continue to grow. It's important to improve healthcare systems to improve the transition from CKD to ESRD, to make it safer. It is not safe now. And I spoke specifically of the timing of initiation of dialysis, which I think today remains in the realm of art of medicine and not the science of medicine. Interventions that are effective in reducing cardiovascular risk in the general population have limited effectiveness in patients undergoing maintenance dialysis. And there are efforts underway to identify interventions for people with ESRD. Improving sense of well-being is as important as improving longevity. And so I think there is a need for us to better identify and treat symptoms as also comorbidities like depression. So thank you for your attention. I'd be happy to take comments or questions.
Thank you. I appreciated your talk very much. In the late 90s, it used to be that if you took new dialysis admission patients and stratified them for age group, the most common, or actually the highest percentage represented age group was the 70 to 80-year-olds. Is that still the case?
Well, I think one has to be careful. If you look at the absolute number of patients in the country that are undergoing dialysis, the single largest age range is 45 to 64 years of age. But if you then use the data to express that per million population of that age strata, it's higher as you get older. So does that answer your question? This is whether you look at new incoming or prevalent patients. Unfortunately, the highest single largest absolute number of patients are people that you can call in the prime of their lives, 45 to 64 years of age.
You have the art of medicine on your slide. Say something more about when you suggest dialysis.
Well, I mean, I think because it's the art, it then is individualized. It is, one of the things that in being a nephrologist for 15 years, I don't know of a patient who said, sign me up to start dialysis tomorrow. So I view this as an iterative process in which I'm working with the patient over weeks in preparing them that this time is coming for them to start with dialysis. The things that I look out for that are potentially subtle and the patients are not likely to endorse are, for example, weight loss. Because people lose their appetite. You ask them if they have lost their appetite, they would say no. You ask them if they have nausea, they will say no. But they're actually losing weight. Subtle signs of volume overload would be another reason why I would be prompting patients to start dialysis. I need to take a step back when thinking of this question because there are two populations of patients that are out there that start dialysis. One that is under the care of a nephrologist over weeks and months and years, and that's the population I'm talking about. There are about 40% of patients that start dialysis emergently, and the reasons for that are very complex. It is either the patient didn't know that they had kidney disease, or they knew they had kidney disease but didn't want to engage with the nephrologist, or they had a little bit of kidney disease and they got acutely ill, and they got contrast because they had a cardiac cath or catastrophic illness, and that causes them kidney disease, or there are some rapidly progressive diseases like RPGN, vasculitis, that cause their kidneys to go in. In those patients, the conversation is much more like coming in with a catastrophic diagnosis. It's diagnosis that patients are very poorly prepared for. So those conversations are different in how they happen.
What about lab results?
I think the only lab results that are absolute indications of starting dialysis is hyperkalemia that is difficult to manage medically. That happens very unusually in people that have slowly progressive kidney disease.
Hello. Thanks for the great talk, Dr. Mehrotra. I'm wondering, how do you think is the best way to deliver care, and I mean specifically thinking about primary care to dialysis patients? You talk already about how they're in the dialysis unit 4 hours a day, but you're also needing to treat their depression or their insomnia or all of these other things. How do you deliver care to someone who's, already has a lot of things you're asking them to do? What's the best way to organize that?
Right. I mean, I think, that is very challenging. It is the one way of saying it would be every dialysis patient should have a PCP. The challenge in that context, that is a very challenging issue because these are people that are required to go for dialysis 3 times a week already. And they are reluctant to go for routine checkups for another appointment that they don't have to go. And so I think in an ideal world that care needs to be delivered in the dialysis unit. What we don't have today are resources to deliver the care. Every dialysis unit is mandated to have a social worker and a dietitian. So at least I think multidisciplinary care, engaging them is important. What is being tested in terms of innovations in care delivery to get to that point is something what we call as an ESCO. ESCO is like an ACO for the dialysis units. It stands for End-Stage Renal Disease Seamless Care Organizations, in which they're responsible for the health and well-being as a whole of an individual, rather than for dialysis, in which more resources are available to deliver that holistic care in the dialysis unit. I believe there are, 10 ESCOs that CMMI has funded around the country, and we will see the results of that to see whether that's the direction where we need to go.
Raj, great talk. Thank you. You showed us in one of your slides that the majority of patients in the U.S. are on hemodialysis. Could you say a few words of which modality is better? Is hemo the same as PD, and which may be more advantageous?
Well, I mean, I think if you look, it depends upon what metric you use. And so if your metric is longevity of a patient in terms of how long they live, there is no difference in studies now from around the world at 5 years, at 10 years, in people that start treatment with hemodialysis versus PD. In terms of the consequences for the patient, the burden of treatment, are unique and different for the two therapies. So that in hemodialysis, the patient is committing to go to a dialysis unit 3 times a week, and then somebody else is delivering the care, versus PD, in which a patient is expected to do the dialysis at home. And people have very good reasons to select one or the other for reasons that are not medical. So the bottom line is, in my mind, there is no medical reason to believe that one is better for a patient versus other. The decision-making is non-medical, that is to do with the values and expectations of a patient and their caregivers in what they expect out of life. And so people ask me who's a good candidate for PD, I say anyone who wants to do it. So it could be anyone, but they have to want to do it. If they don't want to do it, they're going to not do very well on that. And the same thing applies for hemo.
Yes, I have 2 questions. It's been a number of years now that the lab reports the eGFR together with the creatinine routinely. I'm wondering if there's any evidence that that has made a difference in patient outcome or recognition of renal failure, et cetera. And my second question is, one of your interventions is going to be use of anakinra, which is a very targeted anti-inflammatory. That's going to decrease the risk for acute gout and pseudo-gout, but I wonder about the choice of that drug in this population.
Right. I think, so let me answer the first question first, is eGFR. So I actually, there's no hard data I can point to. We were a part of an international clinical trial in which nephrologists were sent case vignettes. They had identical case vignettes up until serum creatinine. One of them included eGFR, the other did not include eGFR. And these were patients with advanced kidney disease, and they were asked whether they would recommend that patients start dialysis or not start dialysis. And the physicians that received eGFR recommended dialysis at a higher level of kidney function than those that didn't. That is the only data that I'm aware of, and this was particularly so in the United States. We had 400 respondents from the U.S. So that was that. So not vignettes. One has to be careful in assuming that how people respond to a vignette is truly how they practice. With that qualification, that's the only thing I know of. Anakinra. The initial drug that we were thinking of was clazikimab, which is an anti-IL-6 antagonist, and with the manufacturer, it just didn't work out. Anakinra is the only anti-inflammatory drug for which there are pilot studies that a 4-week trial has been completed in people on hemodialysis that showed a significant reduction in markers of inflammation, primarily CRP, without a change in serum albumin. So at least there was a 4-week data available on evidence for safety in this population, is why we are using anakinra.